Dear friends, it's really a great pleasure and honor indeed for me to be here on a very special platform. And the platform is Mission Hypertension. You all know that India is the world capital of hypertension. Hypertension is not only a problem for India but also for the globe. I'm sure you all are aware of the data published in the Indian Heart Journal in somewhere in 2015, which has shown very clearly that 42% of hypertensive patients were not aware that they are hypertensive. It's a matter of great concern. And data recently published by ICMR, by WHO, in the Ministry of Health, Science and Technology have shown that 10% of individuals in India are only meticulously controlled hypertensives. It's very painful. That means 90% of patients are uncontrolled hypertension. So uncontrolled hypertension is a real challenge for all of us. I call uncontrolled hypertension as a global tsunami which is responsible for premature heart attack, brain attack, leg attack, eye attack, and nose attack, and even dissection of aorta and acute or a chronic kidney failure, which are very important outcome of uncontrolled hypertension. So what should we do? I think we have to understand that hypertensives can be young hypertensives or can be hypertensives beyond the age of 40. Young hypertensives mostly they have increased sympathetic activity. So they need more beta blockers and they need calcium channel blockers. But those who are beyond 40, we divide into two groups. Those without comorbidity and those with comorbidities. In both these individuals, our focus today is on thiazide diuretics. When I say thiazide diuretics, it means either it is a hydrochlorothiazide, indapamide, or it is chlorthalidone. The distinction should be known to each and every one because the diuretic plays a very important role. When we talk of chlorothiazide or we talk of chlorthalidone, both the drugs they are diuretics which are known to us and they act at the level of proximal convoluted tubule as well as at the level of distal convoluted tubule, thereby excreting more sodium and chlorides as well as the volume, and they also improve the perfusion in the kidneys, and they also act at the level of proximal convoluted tubule at the level of hyaluronic acid. So I feel the drug of choice, first choice today in diuretics, in medical armamentarium is chlorthalidone. What is available very freely as simple to remember is CTD. And it is available in 6.25 milligram, 12.5 milligram and 25 milligram. The data which was available by Alhut study, they've used 12.5 milligram and they found it's very effective. Its safety profile, efficacy profile is beyond doubt. I must tell you today, ladies and gentlemen, with a great zeal of confidence, that chlorthalidone is a metabolic friendly molecule. No hyperuricemia, no tendency for diabetes, no dyslipidemia, and no significant dyslipidemia. Because I know, and you also know, that drug like hydrochlorothiazide or chlorthalidone may cause hyponatremia, may also cause hypokalemia. But this is seen usually in the patients who are very elderly or very elderly. Otherwise, if you see data, it is about 3 to 4% people who have only hyponatremia, which can be easily taken care of. The best thing is combination of chlorthalidone with telmisartan, so that we don't get a hypokalemia. This is taken care of, and it's very safe drug. Now worldwide people are using chlorthalidone or CTD as the first drug of choice, and I firmly believe that the optimum dose should be 12.5 milligram. Why it is so? Because most of our patients in India are suffering from metabolic syndrome. The data, I'm sure you might have gone through Indian Heart Journal in 2007, which was from my own group, which was showing 60 to 65% of patients have metabolic syndrome. They have a LV thickness, LV mass is higher, LV filling pressures are higher, and they are hypertensive. Their systolic blood pressure and diastolic blood pressure both are high. Now if you take chlorthalidone or CTD, it affects both systolic blood pressure and diastolic blood pressure. And there is a huge data to support that clinical blood pressure, home BP monitoring blood pressure, and ambulatory blood pressure are very well controlled with chlorthalidone as compared to hydrochlorothiazide. Number 2, I mentioned to you that hyperuricemia, dyslipidemia and hyperglycemia are almost not seen with chlorthalidone. So that's very powerful potential. Half-life is longer, elimination life is longer, and it is excreted as such in the urine. So hardly any side effects. Third important potential is MACE rate is reduced. Morbidity is significantly reduced. LV mass is reduced, LV hypertrophy is reduced, whether it's eccentric hypertrophy or a concentric hypertrophy. Then the filling pressures are reduced, whether it is LV and diastolic pressure or E by prime ratio or even the LA pressure. So ladies and gentlemen, there are a huge number of benefits of using chlorthalidone on a long-term basis. It's a very safe molecule and helps in conversion of patient from hypertension to so-called HFpEF, which is a real challenge for our country. What else we want? If we control hypertension meticulously and not subject our patient to become a victim of HFpEF and high morbidity and mortality, so I can say indirectly that chlorthalidone has contributed to a very large extent to reduce the morbidity and mortality which is CVD inflicted, which is uncontrolled hypertension inflicted. So I think this is just a brief introduction about chlorthalidone, but there is a huge data available now to compare hydrochlorothiazide with chlorthalidone, and recently I heard some data which is showing that beside the dyslipidemia caused by the indapamide or hydrochlorothiazide, even malignancies are known. And some people are getting more malignancies with hydrochlorothiazide. So, in short, to conclude, ladies and gentlemen, chlorthalidone or CTD is the first drug of choice in patients who are hypertensive beyond the age of 40 with comorbidity or without comorbidity. With comorbidity, it is more benefits, as I mentioned to you, reduction of MACE rate, morbidity, mortality, and of course, reduction of LV filling pressures and prevalence of HFpEF. This is what I wanted to say. So, it is an iconic diuretic for control of hypertension in mild, moderate or severe hypertension up to the age of 40. That's a very important message which I want to convey today on the occasion of Mission Hypertension Care. Thank you very much for giving me this opportunity.